Coming to the bullet points, because we are used to using American terms for slides also. Come.
Now that the rapid fire is over, we should collect whatever bullets were fired. So in the next few minutes, I would just briefly summarize what we learned to these endocrine emergencies. In the session of endocrine hypertension, as we said, clinically suspecting is important, because in endocrine hypertension, not just treating the hypertension, but if it's an underlying tumor, you are making a big deal of a difference for that patient. The tests need to be ordered and interpreted judiciously. In an ICU setting, if I send a metanephrines, they would be elevated and there would be unnecessary cost of that investigation which is incurred. So tests have to be done once the patient is discharged. The tests have to be interpreted in a clinical setting. A huge pheochromocytoma will be expected to cause that much amount of elevations in metanephrines. So if you get just something borderline, whether we should really go ahead and do an entire imaging or not, everything needs to be looked into carefully. In the session of apoplexy, we went through and understood the various causes and how understanding relative functional excess is important. Selecting the right patient for a conservative management is important. Just as a routine blanket, we should not decide that every patient with apoplexy requires surgery, but again, that's a field of judicious selection. One important aspect which we heard in the discussion on hyponatremia treatment, that the physicians were worried about the risk of ODS. That was a good thing, that yes, we know and we are worried about ODS, but not using hypertonic saline for the fear of ODS is like refusing to use insulin for hypoglycemia in a patient whose sugar is 500. So when a patient is really having that severe hyponatremia, so much so that they are symptomatic, we have to use 3%, but judiciously. Use it at a proper rate, do a proper monitoring so that we are not really overcorrecting. Overcorrection is a fear if we do not monitor. Overcorrection is a fear if we just close our eyes and add 3% and tolvaptan, everything together, then we are just facing with erratic treatment. Tolvaptan has its role, but its role is useful and it needs to be chosen carefully and monitored appropriately. In the hypocalcemia session, we understood the various causes of hypocalcemia and how do we approach it. Just a point to be noted was that in medicine wards, routinely any hypocalcemia patient would be getting 10 ml IV calcium gluconate TDS. That is not enough as a prescription. You need to really understand what is the cause. If it is so much severe, the patients would actually require an infusion under monitoring. You cannot just start a calcium infusion on a high rate and end up with another emergency of a bradycardia. And treating a chronic hypocalcemia in itself is an art. You cannot give a patient a CKD because of hypercalcemia and nephrocalcinosis while you were trying to chase and put the calcium in the very much normal value. And as was said rightly, in hypoglycemia patients, when you are faced with hypoglycemia, first collect the blood sample, then give them IV dextrose, because unless the test is done at the time of hypoglycemia, it is of no use. Even you giving me a random HGT is not enough. There is a difference between a capillary and a venous glucose. So a correct critical sample is absolutely important for us to establish the diagnosis. In insulinoma nowadays, with the advent of functional imaging, use of DOTA scan, Exendin scan, localization is becoming increasingly easier, but that patient like a Munchausen in which everything can go wrong, at the end of the day, your clinical acumen decides and takes over everything else. With that, my dear chairpersons, we would like to conclude the session. Thank you for chairing, and may I please request the esteemed faculty to go outside at the felicitation point. We would want to hand you a memento.